I am now, I've got the pleasure of inviting our last speaker up, and so Dr. Shobhit Baijal has very kindly agreed to step into the fray, and he doesn't have a presentation because I asked him if he would be brave enough to come here and take any questions that anybody asked. So this was feedback we had last time, that there wasn't enough time to ask the expert, and people wanted more opportunity to do that. So we've brought the expert along. You have an hour with him maximum, well, a bit less than that now, and Dr. Baijal will answer any of your ALK-related questions. So please don't be shy. I know Claire has one for him. Just putting her on the spot. So please don't be shy, and Dr. Baijal.
Thank you, Deborah. I think I pulled the short straw on this one. I feel fully exposed. But yes, over to you guys. Well, first of all, thank you for the invite. Really, this is a couple of years now I've been doing this, and it's a brilliant thing, amazing. I'm very humbled to be here. So please ask away. I can't promise I know the answers to everything, but if I don't, definitely I will go back and do some homework for you and get your answers the best I can. So please fire away. I like the shyness.
Can I actually just start? I want to say thank you to you personally, because I met you a couple of years ago in Birmingham, and you gave me the strength to go to my oncologist and say, excuse me, why am I not getting brain MRIs? I know I need them, but you say, oh, no, you don't. And I've been having them since. So I just personally want to thank you for giving me the power to do that.
Oh, you're welcome.
Thank you. I'm Adeniki, and I'm from Birmingham. We met last year, and I did say, who are you? I mean, I'm from Birmingham. I'm from University Hospital Birmingham. I've never met you. But I did say, you are from Good Hope. Good Hope.
That's where I put, yes. There's a few of us in Birmingham.
Okay, I'm under Professor Middleton. Now, I mean, this question was asked yesterday, but I didn't actually quite get the answer about it. And it's about liquid biopsy. So what's going on about doing because we dive into American conference, and there's a lot of a different set of system in America. But one of the things that they said was second opinion and all that, and you can, how do we know that we are not cured? I mean, we go there, they said, oh, the thing in your lung is gone, the thing, everything is stable. But they said, well, the thing you need to do is like, unless you do a liquid biopsy or blood biopsy or something like that, you won't know. So just for enlightenment, please, if you could. Yeah.
So I think there are two angles to that question. Or there are two aspects to liquid biopsies that I think you're alluding to. So the first, so liquid biopsy, it's a phenomenal tool that's entering our arena, our diagnostic arena. And there are two parts to it. So one, so the aspect is that from the blood we can harvest tumor DNA and interrogate that. So there's a lot of work going on at the diagnostic aspect. So this is when patients, when yourselves would have first presented with symptoms. And as we know, pathways can be a little bit drawn out in terms of getting your biopsies, etc. So there's a real interest in liquid biopsies complementing tissue biopsies, or even replacing them for certain patients at that diagnostic aspect, just to speed it up. We know it's a lot less invasive, so we can get a quick blood test. It does still take a bit of time to get that analysis, but we can get a broad spectrum of mutations. And really where it has its greatest utility is probably in those cancers where such as ALK, where we find those driving mutations in those patients that have minimal or no smoking history. So there's this kind of move towards, can we actually expedite diagnosis for these patients? But we won't always get everything we need. The other aspect is that similar interrogation, but if the cancer's progressed. And we want to try and again find out, and I know you probably have had talks about what we know can happen after the cancer gets resistance to your targeted therapy, and there's certain escape mechanisms. And again, we can sometimes interrogate or get that information quite from it is simple in terms of what it is for you in terms of a blood test, but we can get quite sophisticated information. But it's not the be-all, end-all. It doesn't give us everything we need. We don't always harvest that DNA to give us enough information. And there are other escape mechanisms that we can't get that information from a liquid biopsy. We still need that tissue biopsy for. So that's the diagnostic aspect. There is another aspect to liquid biopsies where it can give us almost a bit like your scans, an idea of, well, how is the cancer responding to therapy? So it gives us almost like a quantitative, a number value. So say you start, just for argument's sake, if we did you can do cell counts from it or DNA. There are different tools. These are a different type of interrogation of that liquid biopsy where we get almost a number figure for somebody, that this is where your cancer is at diagnosis. You've started treatment, the treatment's working, and that number drops. So a bit like, it's again a surrogate for a CT scan telling you that the cancer has responded, but you can get this information from the blood. Now, I've got to stress that is only in the realms of clinical trials at the moment. That's not in clinical practice. And I think that's what you're alluding to. And there is data in ALK space, in the EGFR space, to tell us that those patients that clear their DNA early on will probably do a lot better on their targeted treatment. But again, this is all trial data. It's not in clinical practice. But if you clear your ctDNA, it doesn't become a surrogate. I'm not sure where that information, it doesn't become a surrogate that the cancer's gone. It's a good mark, it's a good sign, and potentially the emergence of it, and we have seen that in trials, that the emergence of the numbers in the blood can sometimes precede what we find clinically on scans and things. But again, it wouldn't be a surrogate for what I think what you're alluding to is the cancer gone for good. Unfortunately, although the treatments are brilliant and hopefully they will work for you all for a very long period of time, the cancer is still there, but it's subdued. Does that answer the question? Okay.
Thank you. I wanted to ask about the residual nodule that's left, the bit that can, for me personally, can still be seen on the scan. I had a large pleural effusion, so I had pleural involvement. That's all cleared. But 4 years on, I still have that little odd linear-looking area. And every so often I say, can we not just take it out? So, why are we waiting for it to grow again? Can we do the surgery, or can we do the radiotherapy? I know maybe the whole trial is part of that, but I just wonder what the views were now about that. Yeah,
it's a good question. It's a very tough question to answer. It's very individualized to, what started off. As you said, you had the fluid. Was there any, there are other aspects that probably need to be brought into that. There's no, and I'll talk about Holt as well if you want, there's no simple yes or no to that. I mean, the real area where that kind of, or what I'd say local therapy really does come into its own is if an area outside of everything else starts to progress and everything else is controlled, or just only minimal lesions. There, definitely I would advocate a targeted approach to that area. If you're in a position where, yes, you started with X and now all you're left is Y, I wouldn't say it's a no, but there has to be a biological rationale that you really feel that everything else that was there has really been dealt with adequately. What are you hoping to try and achieve by attacking that one area? Because, again, I guess similar to the previous question, unfortunately, there probably is, as I said, that's where it becomes individualized depending on what you started with. The likelihood is there could be more going on that's under the microscope that we can't see on our scans, these microcells. So there's got to be, and also coming into that factor is, well, how aggressive will that management be to try and tackle that? Is that going to keep you off your TKI or your treatment for a long period of time that then may compromise other aspects? So there's a lot of factors that have to go into that. With the unknown entity, we don't know. If that is the only area, brilliant, and it's dealt with, it's gone. But without that kind of retroscope, we wouldn't know whether we're going to do you any good or cause you harm. So it's a very good question. And as I said, I think it's something that we as oncologists, if you approach oncologists, it shouldn't be dismissed, but it should be thought about. And if there's a rational reason not to, but if there is a rational reason to go for it, I can't promise you it would be an easy ask. That it would have to be a lot of thought gone into it, probably a lot of further investigations. Maybe that's where a PET scan might come into play, really aggressive test to make sure that this really is the only area or site that we now think is there. Let's rethink the plan. We can always go back. We shouldn't always think, well, that's it. It's only about drug treatment. If something looks different or seems that we should be able to tackle in a different way, we can always think again or think outside that box. But it's not an easy one, and I can't say, look, that's definitely the right. There's so much that would have to go into that. And again, if you went into it, there would be a huge element of uncertainty of what would be achieved by doing that. Okay.
All right. My question is actually related to the last one. Essentially, we have some of the cancers that we know. Suddenly, they tell you, oh, it's gone. The patient is cancer-free. My question is it not possible with the ALK, patient as well, that at this stage, is shrink, is stable for years? How can you just tell us whether now you are now cancer-free? That's the first one. My second question, correct me if I'm wrong, I read something about vaccination development to go along with the TKIs. Any progress about that? Okay.
So to take your first question, I'd love, I have many patients who are doing brilliantly and we're years on and, the scans are good. And I'd love to say, look, you're cancer-free. And obviously with a room full of people living it, I'd love to say that to you. Frustratingly from our side and of course from your side, it's not the reality. Yes, there will be some patients, very, that exceptional one where things just never do wake up and they just, we always get that little, where you see these graphs we always show, there's always that little tail right at the end. But sadly, we know that resistance at some point does develop, and excitingly, as I saw the agenda for yesterday, and we'll talk about vaccine as well, there is a lot going on to again push to that next level and next level. So I know from an oncologist perspective, treating lung, ALK is that kind of golden child where we think we're smashing it, we're doing so brilliant. But I get it from your side, there still is this, well, we're not there yet. There still is this, well, at some point, sadly, there's a chance that things are going to become resistant. But there's still a lot of work going on. But with our TKIs at the moment, as brilliant as patient as yourselves are doing, unfortunately, we're not at that point where we can say it's gone. The vaccine, yes, there's been a lot of hype about that over the last couple of years, and I think rightly so, a lot of excitement about this. And there was a paper earlier this year so it's still in that preclinical phase at the moment. I think there are two aspects. There's obviously the ALK-specific vaccine, and there's a lot of just vaccine work going on anyway in the cancer field. But I guess the interest is of this ALK-focused one, where the development is focused on what we call ALK peptides, or the actual using bits of what we know is the ALK, so you can target those ALK cells to try and inject them in a way that the body then recognizes that as a foreign body and attacks it. So the data from the preclinical, so that's the stuff that does before the drug gets us patients, looks encouraging. This is on kind of tissues that are grown in the lab as well as mouse models. And it's using the vaccine in combination with TKIs, in combination with what we call checkpoint inhibitors or immunotherapy. But it hasn't reached that stage yet to first in man. And it is, I know it's, again, frustrating for yourselves, why does it take so long, but it is a big leap to go from that to that, and these things are not going to be quick fixes, but hopefully in the next year or two, I'm hopeful we will be, as long as these mouse models, or the first thing obviously then when it enters clinical staging is, the first question is it safe? And we never know that till we try it in patients, sadly. As much as the safety we can see in the preclinical phase, we never know, and that would be the first question that would need to be asked or answered. Then, obviously, we then want to look at, is it doing what we want it to do?
Hi, Doctor. Thank you for taking my question. I'm at a bit of a crossroads. I'm actually from Dublin, so I'm not an NHS patient. I've come across just invaluable information this weekend, and I guess my question is that the week before we came away, on the Monday, I had my visit with my oncologist, and relating back to, I guess, my primary nodule is starting to grow. So I had started with a pleural effusion, I'd lost my voice, my cancer had spread to my eye 16 months ago. So I've been on the alectinib up to now, and had been obviously working up to 6 weeks ago to the last scan. So obviously when we had our 6-week visit with our oncologist after the last scan, then the node is obviously starting to grow again. So come back on 4 weeks, which we did, which led us up to last Monday. So the decision with the team was to change to lorlatinib, whereas I was hoping to maybe weed the garden, maybe with a bit of, obviously depending on where the node is, apparently it's not suitable for radiation. Now we've requested a second opinion to see a radiation oncologist, and I would also like to see an ALK specialist, because I believe my oncologist is not an ALK specialist back in Dublin. But my question is now, I guess, that my fear is I have to wait another 6 weeks, is what they told me, for another CT scan. And I guess the frightening part is, of all the things that I started off with, my eye, my voice, I think they took 8 litres off my lung with the pleural effusion. I don't want to wait and remain. My oncologist told me, she was happy now for me to wait and finish out another 6 weeks on the alectinib, because I told her I wasn't kind of happy to start the lorlatinib kind of almost instantly, because to me it's the last in the TKIs and it's quite scary. So I'm just wondering, should I wait? Yeah, we're kind of the crossroad is, should I start the lorlatinib almost instantly, or try and go with the options?
Yeah, I mean, again, without knowing the full case, it's always a little bit difficult to comment, but if I can speak generally in terms of managing ALK, that phrase, I like what you said, you wanted to keep weeding the garden. I've not heard that one before, but you're right. Well, it's called treating on progression, or managing what we call oligoprogression. So oligoprogression means either everything's growing, or progression can happen in different ways. One, everything just growing very slowly. So too many areas for us to target one, but I wouldn't advocate jumping ship. We get this sometimes as millimeter here, millimeter there. That's all right. It means that the majority of the clones are still sensitive to your current drug. So let's not jump ship. Yes, there clearly is some level of resistance building up, but it could be months or even longer before you need to then reach out for your next drug. Then there's the scenario which I'm assuming you're describing, where there's just one, maybe 2 areas where...
Well, I believe it's just the one.
The one area. Now, yes, so I'm a believer, and the trials allowed this, and I think most of my ALK expert colleagues would also advocate that you manage the progressing lesion as a separate entity to the rest. That's where, so again, what that's telling us is that your current drug is managing the rest of your disease. So those clones are still sensitive. Clearly, in that one area, there are now resistant clones developing. So it makes biological and rational sense to target that area with some sort of local therapy to then allow you more time on your current treatment. And all the trials, we look at this now, and the trials all show on average, you can tease out quite a few more months, exactly, you're right, before you then have to move to your next drug. So again, as I said, without knowing that your full case, that is something that if you're under myself, I would want to be exploring all options for that. It depends where it is, and I don't know what the rationale is why radiotherapy isn't an option. There are some issues with what can you access radiotherapy-wise. There are different types. Well, I guess there are lots of different. First of all, radiotherapy isn't the only focal therapy you can think about. Okay. If you've got an engaged team, we talked about surgery. It's not, if it's a simple, no surgery simple, but if it's a simple nip it out, and it means you're not going to be off your drug for too long, then that's something to explore. We can burn tumors. There's procedures called radiofrequency ablation, microwave ablation. So I've got colleagues that do that where we can stick needles in, burn tumors. Again, something that we use quite a bit for what we call the oligoprogressing lesions. Radiotherapy is clearly the least invasive, and if you can get what we call stereotactic, or the more focal, multiple terms for it, stereotactic, cyberknife, this means delivering a very high dose to that one area. Again, that's favorable because you get a very high dose with very minimal damage to the tissue around. But commissioning for that is not straightforward. It depends where that area is. Depends on what and again, so sometimes you can play a little bit with the wording with your clinical oncologist, and so it depends. But the final options, and I have been in that situation where we can't get away with any of those other options. It's not RFA-able surgery, it's clearly not an option. SRS or stereotactics not in there. There are other forms of, so even old school radiotherapy, but we deliver a high dose with it. If we think actually we're not going to damage the rest of the organs, all right. Something we play with a lot of it is what we call high dose palliative. So it's not a radical dose, which is very intensive. It's not just, it's not a dose that patients can sometimes get for pain relief, which kind of sits on the lower spectrum. We kind of give somewhere as a middle house, which does serve as a good holding mechanism to try and sterilize that one area. So I think you're definitely doing the right thing to get an opinion from somebody. I hear you about, obviously, the delay. Well, I don't see why you can't get an opinion on your current scan. Sure, whoever wants to treat you will want an up-to-date scan, and but there's no reason, again, if there's an agreement that, yes, this is treatable with some sort of local therapy, you're definitely in your rights, and that then requires another scan, you're definitely in your rights to say, well, we don't need to wait 6 weeks. This treatment depends on that. So I would pursue that second opinion, but say, look, I don't want it on the up-to-date scan. We've got that information. All I need to know is on that last scan, is this treatable? Okay. Yes or no? If it's not, and there's clearly a technical reason why radiotherapy isn't, and all other options for local therapy have been explored. But then I would also go back and say, if all that has been explored and there clearly is no option for you, then I would again say, well, look, what is the change? Is it 5%, 10% growth in that one area? Again, I'd probably say, well, let's just sit tight maybe, leave Lola for a little bit longer. So there's a lot of factors that go into it. So again, even if it's not treatable with local therapy, there's a lot of oncologist discretion into what actually matters. What is clinical progression? Are we losing control? We really need to make that switch, or can we tease a bit more out of it? And there's no rule book on that. There's no strict guidance on that. It really is experience and clinician discretion on that.
Okay, it's just, as I say, it's just the time factor for me now. It feels like, I need to make a move on a decision one way or the other. So it's either start the new tablets or to really push to get the second opinion for the oncologist and the consultant radiologist, which, again, if a scan, it needs to be taken, it's just the time is so sensitive.
I agree. No, I'm with you on that.
Yeah.
And I would just say, looking at you and hearing you, you sound well. We worry when not just scans aren't right, but people are feeling changes of cancer. That's a worry that actually we do need to do something. I'm not saying you should sit on it, but I think you've got a bit of time to say, well, let's look at this properly.
Okay, thank you.
Okay.
question for you. It's coming from...
Sorry, sorry.
It's okay. Yeah, this has come in, and they weren't able to attend the conference, so they've asked this question. NICE guidelines. Would clinicians like more freedom around the use of the TKIs? And I suppose that they're talking about alectinib, brigatinib, first line. Now, I know there is a 3-month window, but outside of that. So basically, do clinicians generally feel that NICE guidelines are fit for purpose?
I'm surprised I'm saying this, but I think, at least of recent years, NICE have been pretty generous in their approvals for treatments in lung cancer as a whole, and definitely in the ALK field, I think, bar the recent decision on lorlatinib first line. But I think, I think we've got an option of all TKIs. You could argue that ones that we probably think, so we've got still access to the first generation, we've got access to 3 second generation ALK TKIs. And I think they're made on rational decisions, and I think it's given us the flexibility to use them. No one's there to, we have got free rein to use whichever one we want. Should that be narrowed down to just alectinib and brigatinib now, based on current data? Probably. But the field is open. There is the option to play between the different ALK inhibitors within the first 3 months if there's a problem with side effects. So you can switch, but once you've reached that 3-month mark, at least on brigatinib and alectinib, you can't then go back to a different one. I think in being, we're working in a health service which does have a limited budget. I think I definitely feel like I've got the tools that I need to treat my outpatients. Is there ever a time where I might want to go back to one of the ones where I'm not allowed to? I think those scenarios are pretty rare, and I think the ALK field now is evolving in a way where we're probably now looking forward. So I think in terms of the drugs that we've got as a choice, I think NICE is fit for purpose at the moment. I do sit on quite a few, and with Deborah, who does a great job representing yourselves, who sit on NICE appraisals. I'm not a fan of the process. They don't always get the science, what it means to you as patients and carers. But that's what Deborah's there for. That's what I'm there for, to really push the science and push the data and try and make them see that this isn't just a numbers game. But I think with all that taken into account, I would say yes. I'm happy with the way NICE is approved and what we've got access to. And because of one of the benefits of coming out of the EU means we do actually get approvals for drugs much quicker than what we used to, which again is a plus.
Hi, sorry, this might's kind of be similar to some of the others, but I was on alectinib for 3 years, was doing really well, and then for the last 4 months I had to go in and out of hospital, and they took me off the alectinib because I had bad infections, etc. When I came out, I had a scan, and my oncologist, who's not ALK trained, said that there was a slight progression on my lung, but nowhere else, and wanted me to change straight away to lorlatinib. I was kind of unhappy about that, but I went along with it, and since I've only been on that a couple of months, I've not been that well. I've got fluid on my lung, etc. They did a PET scan and said that the cancer's literally gone everywhere. Would that happen in that short of time, or should I just feel that I was so well on the alectinib and then suddenly, boom?
It's cancers do. I know there's obviously lorlatinib, post-alectinib is there, and it's a great option to have, and it probably goes back to the topic we talked about, escape mechanisms. And so lorlatinib is there to manage an escape mechanism that we know can happen after alectinib and brigatinib, one of the G1202R, which is the common one that can happen, and that's where it really comes into its play. But we know that not everybody's going to have that escape mechanism. And that's why, yes, some people will do brilliant on lorlatinib, but unfortunately it won't work on everybody in that post-alectinib, brigatinib space. And cancers, when they do wake up, they can do it in different ways. Sometimes, again, we talked about that slow growth. Sometimes it can be more, it can gather more momentum. And I think definitely you're somebody that I would really say needs to have some sort of repeat biopsy to know what's going on. Sorry?
Could the mutation change?
So it doesn't just have to be the mutation. So there are three pathways where the cancers will develop resistance. One is down the ALK pathway itself, where yes, it can acquire a new mutation, and it can also acquire what we call co-mutations or compounds, so two mutations, and that's where potentially the fourth generation ALK inhibitors are going to come into play. So that's your one pathway. The other pathway is where there may be another escape mechanism. Some of those are down a pathway that we already have targeted drugs for, something called MET is a very common, not common, but is one of the more prominent ones in that field. There's EGFR, HER2, HER3. There are escape mechanisms for which there are treatments. It's not always easy to access the drugs. There are ways to get them, but using the drug that targets the new alteration, but keeping your ALK inhibitor going, as I said, it's not an easy, you've got to probably phone a friend and make a few inquiries to try and access the drugs, but there are ways to get it. But it depends if you've got one of those. But also within that middle section of non-ALK alterations, there's a lot can happen which we just don't have targets for. And that's where there's a lot of work going on for that group. The final aspect, which is rare but can happen, is so you start off, most of you, or 99% of you, will have what we call adenocarcinoma, and that's where we find the ALK. And that's kind of what we see under the microscope. Our pathologist sees it as the type of lung cancer you have. Rarely, but it can happen. Your cancer can mutate to other subtypes of tissue, something called squamous cell or even small cell. That you can only tell with a tissue biopsy. And that's why I was saying when we're talking about blood biopsies, you can't get all the information you need off a blood biopsy. But I think if that is what's happening, definitely is probably where I would say the point where your oncologist needs to think about how can they interrogate that tumor or your cancer to try and work out what's next. And I can't say that we'll always find something that's targetable, but if not, and lorlatinib is really not working, that there are trials going on for kind of next generation drugs. There are also, we shouldn't dismiss chemotherapy, which is still a very effective option. I know it sounds scary, and I get it for patients who've been on tablet treatment for so long, but it still is a viable, effective treatment option.
What about radiotherapy? Because I've had that, when I said it went everywhere, I mean, it's in my lungs still, and obviously quite bad. It's moved around my bones, luckily not in my organs. I did have it in my liver, but the alectinib cleared that up. I've had radiotherapy twice, and it worked exceptionally well for pain relief, and the tumours couldn't be seen on the MRIs. Where does how, obviously it's quite hard to get radiotherapy sometimes. I've been quite lucky that my radiotherapist will give me, as she says, slightly higher dose, and I'm due to have that again next week. Can they not just pinpoint those bits with radiotherapy rather than having to go down the chemo route? Is that still not available to us?
I guess it depends on it depends on how much is involved and what areas need radiation. So every organ has its limitations, and that includes the bone as well, in terms of if it's in the spine or in the hip. There are, it depends how many spots there are. So unfortunately, every organ has a tolerance to what it can take with radiotherapy. So it's not it depends, as you said, if you've got a couple of spots here and there, I guess it's not an impossibility. But it does depend on how extensive, when you say it's come in the bone, it is. So, and your oncology, and in terms of that kind of what we call that dose for pain relief, there shouldn't be any commissioning or limiting options for your radiotherapist. If they think you're going to benefit from it, then it should be an option. But as I said, my guess is, or I don't know, but there is a limit to how much involvement there is that a radiotherapy would be suitable for. And that's even kind of, the more conventional old school type radiotherapy.
My oncologist is obviously not ALK specialist, but I don't want to upset him either. Having a second opinion, is that kind of viable? Is it something that generally happens? I know everybody keeps saying to me, get a second opinion.
It does happen. Happens quite a bit.
Nobody gets offended.
Everyone's different, but it does happen. But you've got to remember, yes, you don't want to offend your oncologist, and I get it, and you may end up back there, but this is you, this is your journey. You've got to get it right. And what I would say is, none of us are trained in ALK. We're all trained in lung cancer. I guess there is a group of us that probably have, taken this to another step, especially for the ALK patients. But there are good general oncologists out there, and I think what I always say is if you're doubting something, you've not got the faith, or you've lost faith, there's got to be a viable reason. If your oncologist is not being able to give you the answers that you're asking for, then it's a rational reason to. And it might be that 9 out of 10 second opinions that I give, I actually agree with the oncologist. I just don't think it's been the information's never been communicated in a proper way to the patient, is what I find. But occasionally, we do think actually we would have done things slightly different.
Hi. I hope this isn't a daft question, but if a patient's gone from the standard 1,200 milligrams dose of alectinib and they're down to 600 and everything's stable, if then progression comes along and it's not too aggressive, would one of the first options be to increase the dose of alectinib and then monitor the side effects?
Again, really good question. It's not a black and white answer to that. It would be partly driven by what drove the dose reduction. So how serious was that adverse event? That would I be really worried that if we pushed up the drug, we could end up in some sort of serious scenario? And exactly as you said, what is the level of progression? Is it a little grumble that means actually we could try this? Usually, going up the dose based on, and again, if we go with the trials, a lot of the time in the trials, when you went down a dose, patients didn't then go up a dose. So there'd always be a question, and if somebody's done really well on a lower dose, that's probably the right. I always encourage patients, don't worry if you drop the dose. If it's working, that's just we found the dose that's right for your body. So if that's been doing what it's doing, biologically and pharmacologically, increasing the dose, just putting more of the drug in the body, if you've got resistant clones, it's resistant to that drug. So theoretically, just increasing the element of concentration in the body is probably not going to overcome that. But it's not a no, and as I said, we don't know the answer always. So if I felt actually, look, you've been all right on this dose for so long, it's only a little bit of a grumble, let's just try it. First of all, see how you cope with the higher dose, see if it makes a change. It's not an absolute no, but I'd always be very probably hesitant that we're going to actually do any good with it. But I think if there was a bit of time to try that out, it's not certain. That's why it's not a black and white answer to that. But I think it's probably not, and if it's probably not a strategy that I would have huge faith in to turn things around.
Hi, Doctor. Sorry, it's over here, Yvonne.
Sorry.
Hi. I just wanted to ask, one of the things when I was first diagnosed stage 4 and put on my therapy, I just felt like we're passively waiting one day for the drug to stop working. And that's like the mental game we're all in, right? We don't know how long it's going to work for. So I just wonder what your thoughts are on the role of local consolidated therapy. I know it's not something that's typically done here in the UK, but what are your thoughts? Should we be considering, is that kind of a future movement that we should be thinking about, whether it's introducing a trial to prove this is the right thing for us? And then just a second question, if you don't mind, is what kind of trials would you want to see here in the UK? What is a thing that you think we should all be looking for all of us with ALK?
Okay. So just to understand the first question, do you mean where the disease localized in an area that we could then target it with?
Potentially, some of us might be eligible for LCT, whether it's radiotherapy, surgery, or even, what's the other one, chemotherapy. Some doctors still do that and find that's a way of giving you a boost to keep you on your targeted therapy. Because what I've read is that the science is you want to stay on your first target therapy for as long as possible, because after that your disease starts to get more and more out of control each time, right? Okay. So how do you do that?
So there are a couple of aspects to that. So the first one is sometimes we're in a position where we always have what we call an MDT. So we'll look at the scans and say, well, this is too advanced for any curative treatment. So this is what we think is going to be about containment. And we'll start treatment, as in, say an ALK TKI, and things shrink down quite significantly and actually become in a field where, well, could my radiotherapist actually encompass all that into one field? Maybe it was locally advanced for another reason and surgery wasn't on the card. So it goes back to what I said before, is you can always take a step back and rethink the plan and say, well, actually, can we be radical here? Doesn't happen too often, but I can definitely think of scenarios where we've gone back and said, well, actually, let's stop the drug. I guess it's an element of a known entity, but let's stop the treatment. Everything looks favorable. We could encompass this either in radiotherapy or another form of treatment and zap it. So that's one form of what I would say local consolidative therapy, but slightly different. And most of those patients will be in the kind of stage 3 high category, 3B, so everything's usually in the chest. Now, I think the other aspect you're talking about is, should we be mixing in other drugs with your TKI? If in the scenario where the cancer's controlled and working with the TKI, without trials to show us that that would be of benefit, I would be very concerned about saying, well, you've done 2 years on this drug, shall we try 3 months of chemo, and then see what happens, and then go back? We just don't know what we're going to be doing to the biology of the cancer. And the potential that one would be introducing side effects that are going to be highly unfavorable without, again, a controlled trial to tell us that information, but also the unknown entity of are we actually going to do you more harm with doing that? I think it's a different question if the cancer's growing at that, we talked about that slow growth. Do we still just watch and monitor it, or do we throw something else into the mix? I'm sure if you're in the US, they'd probably add in a bit of chemo to your ALK inhibitor, but again, we don't know truly, is that beneficial? There have been some data sets out there, what we call retrospective data. So this isn't a trial that patients entered into of keeping your drug, your TKI going, and then versus keeping your drug going and adding in chemotherapy. These are looking back at what people had already done and then looking at the data. Now, there's always a lot of bias in those kind of studies, and the studies or the papers that are out there are very small numbers. There is a suggestion that if patients are progressing on lorlatinib, if you keep the lorlatinib going and then the chemo, there was a suggestion that was beneficial, but always take retrospective data with a pinch of salt. They're very selective. You are selecting your patients for that data entry, if that makes sense. There's a lot of bias that gets put into it. So without the trials happening to tell us that's the right thing, I'd always be a little bit hesitant to do it. The next question was about trials, wasn't it?
More about, I guess, leading to that, what trials would you want to see in the UK? What are you excited about in ALK?
So I think the big excitement at the moment, and I think there's data potentially coming out next month, is the 4th generation TKIs. So Nuvalent, the 655 agent, there's obviously a lot of interest in that. But again, I would stress that that's only going to be beneficial probably for those patients. We talked about those escape mechanisms, but those patients who have still got an ALK-driven escape mechanism on their lorlatinib. There is a lot, so that's very specific to that. So I guess the real challenge is, well, what else is out there for where it's not ALK-driven, which unfortunately does affect quite a large proportion of patients that will progress on lorlatinib. Now, we've already talked about chemotherapy, but there is a lot going on to make chemo more sophisticated. there's an array of different agents on the scene. There's something called antibody drug conjugates. So this is almost smart chemo. This is delivering, so the cancers are driven by ALK, and chemotherapy and your ALK drugs target the ALK pathway, so that's how they inhibit those cancer cells. Chemotherapy just blindly kills cells that are dividing, and that's why you hear about the side effects associated with that. So the next class of chemo, the real buzz at the moment in the kind of oncology field generally is about a class of drugs called antibody drug conjugates. So these are drugs that are designed, so the cell surface of cancer cells express certain proteins, and those proteins may have nothing to do with ALK, and they may and often do not drive the cancer, but they become a beacon that say, look, we're here. And so what we can do is then, so these antibody drug conjugates have what we call an antibody that recognizes that beacon, so it can target that beacon, so it's delivering that chemotherapy, almost think about it as smart chemo, onto that, the cancer cells, and it has chemotherapy attached to it. And once it gets taken into the cancer cell, the chemotherapy is released and then kills that cancer cell. But at the same time that cancer cell dies, more of the chemotherapy gets released, and you get this kind of what we call bystander damage, so more cells take a hit. So these are already on the scene in non-ALK space. I've run a couple of trials so patients didn't have to have ALK, they didn't have to have any driver mutation, but ALK patients were allowed if they had exhausted their ALK drugs. So these trials are happening at the moment, and there are different agents targeting different receptors. For some of them, there is actually some specific data out there, very small numbers, but for patients with mutations like ALK and EGFR, definitely showing signals. So I think that's a space to watch. I think smart chemo, there's a similar aspect happening with radiotherapy, a little bit behind what we're seeing with chemo. So again, smart radiotherapy, where in a similar way, you have a radioactive isotope attached to a marker that then can hone in on the cancer cells. That's a lot more complex to deliver, a lot earlier in its development, but I think something, again, to watch out for. And there are other ways of manipulating the immune system as well that are coming through. And we know that ALK, it's with immunotherapy on its own, it seems to be what we call an immunologically cold tumor. So if we give you, or treat it with immunotherapy as a drug on its own, we see very little, if no, activity. But there are new, again, classes of drugs coming through that can try and stimulate that immune system in these immune cold tumors, potentially, again, something to watch out for. So there is a lot going on, I'd say ALK specific, so we talked about the fourth generation inhibitors, we've talked about vaccines, but also there's a lot going on, which is really focused in lung cancer as a whole, but I think will definitely come into play, hopefully, in the ALK space as well. And maybe, again, that's, trials may have, these chemotherapy, because of their smart chemo, they are, I'm not going to say they're side effect free, but they are better tolerated than conventional chemotherapy. But I think the world has to develop, we need a better understanding of markers on ALK tumors that can become beacons for these drugs. So there is a lot going on. I know, I hear what you're saying, you're sitting there just waiting for it, but you're on the right pathway. And although it's easy for me to sit here and not be on treatment and be in your position and say, you're doing the right thing by just sitting and staying on that treatment, but it definitely is the right thing. The time to act will be if things start to progress. At the moment, there is a lot of work going on in that space. Okay.
Across the world, it seems to be fairly consistent for ALK that the median age of diagnosis is around 50, and it seems to be a little bit more prevalent in women than men. It's, as far as I know, that's similar with EGFR and possibly the other oncogene-driven lung cancers. Are there any theories of why we're seeing those particular patterns?
No, not in terms of the reason. There has been some interesting work that was presented, I think, a year or two ago now. So there's something called TracerX, which is Charlie Swanston's work, where he's been looking at what we call cancer evolution, trying to understand why or how cancers develop in the first place, and then also look at how, when cancers progress, looking at resistance, looking at clonal evolution within that. And what came out, interestingly, a year or two ago was a publication. Again, this was mainly focused on EGFR patients, but I guess the principle might stand true for other driver mutations, or those cancers where we know there's patients get it without a smoking history or significant smoking history, which is that there may be, there's the acquisition of one hit that causes the mutation, but that in itself isn't enough to drive the cancer. But they did big population studies to look at certain pollutants that may be a contributory factor, and there is some theories that may actually be that areas where we are seeing high concentrations, that the patients may have been exposed to certain pollutants that are driving that. And why that's of interest is there are ways potentially, so we know what those pollutants now, or there is an understanding, which again, sorry, goes back to your previous question about other things that are going on, what level of inflammation that then causes that it leads to this cancer change. And there's certain cytokines, interleukin beta, one of them, that seems to be a key driver of that. So again, could that be a therapeutic option to prevent the development of these cancers in the future? We'll have to see.
Hiya. Hi. Thank you. It's a slightly similar question to one asked earlier. I was diagnosed just at the beginning of April this year and was started on alectinib at 900 milligrams because I was pregnant. So I've been lucky that that's had a really good, I've had a really good response to that with quite minimal side effects. So I was having the conversation with my oncologist last week about whether or not to increase the dose to 1200 now that I've had my baby. Is there any benefit to that, do you think, given that I'm already responding well at the lower dose? My oncologist couldn't really find much literature on that.
Yeah, your oncologist there won't be any data on that. But I would say from my perspective, there's clearly a rational reason to start you on a lower dose. In that scenario, would see no harm in seeing how I'm assuming, you're now, the pregnancy's over and you're ready to, metabolically you could then, or there's no risk factors for you to go on to the higher dose. So, I mean, your oncologist did well to find out the 900 milligrams. So, hats off to your oncologist on that to find out a safe dose, because that's a very tricky situation to be in. But we don't know. But I think in that situation, I probably would feel quite comfortable, say, well, let's go to full dose now. A lot of patients cope very well with full dose. A lot of patients need to go on lower doses, but for you, there was no, side effect or toxicity reason that you were experiencing that drove you to be on a lower dose. So in a scenario of a known entity, I don't see any harm in going to the full dose. And, I'm assuming it's not been an excessively long time that you've been on 900 milligrams. So, yeah, I would try it. But again, there's no science to tell us either way. But I think that's definitely a rational reason to try it.
Brilliant, thank you.
Okay. Making my neck work today, aren't you?
Yeah. Thank you. My question is, I guess it's quite broad. In your experience, in your personal opinion, what's dynamic now in terms of diagnosis? In my time, my walk, as I call it, with cancer, there's a lot more younger people being diagnosed. We've now taken out the option of smoking, or there's less people smoking, for sure. So in terms of diagnosis, earlier diagnosis across the ages, what's exciting, what's dynamic, what's developing in terms of seeing people earlier in their journey with being diagnosed or tested, for example?
There is a lot going on, but frustratingly, what is happening at the moment would still probably exclude the majority of yourselves. So the biggest thing at the moment, the biggest headliner is lung cancer screening. But that is clearly focused on patients that have a certain element of smoking history, known diagnosis of COPD, so that will not pick up majority of patients with driver mutations. There is work just going on generally. I mean, we you know, everyone knows that pathways are drawn out and frustrating. I mean, I guess there's two aspects. One, what can happen in the community to get patients referred sooner, and I think that's probably the biggest Achilles heel for people who haven't smoked and are going back to the GP with a persistent cough, and lung cancer is not on their radar. And I think the only way that can improve is with education. That, you know, these red flag symptoms, if you get it in a never smoker, you should still, you know, primary care should still be thinking about cancer. The other problem at the moment is, and there's always an issue pre-COVID, COVID exacerbated, is hospital pathway. So when a patient gets referred in, that drawn-out pathway to getting your scans, biopsies, etc., it can take, you know, there are certain time periods that the NHS stipulates with the cancer pathway, but most trusts are failing those because they just haven't got the capacity to get things done. There is a lot of work going on in that, and we're sitting on 2 national bodies to look at driving change from that perspective, but it's not a simple fix. But I think the biggest challenge definitely for a never smoker population is primary care. Getting those referrals in, I think, is the biggest challenge. And sadly, that's one of the reasons why the majority of patients with EGFR, ALK, other mutations present with more advanced disease, because those symptoms just never were picked up in time.
Hi, thank you. Just going back to what you were saying about Tracer X and the exposure to pollutants with driving cancer in the first place, I just wondered whether there's any evidence to show that ongoing exposure to pollutants might then drive progression, and whether in terms of looking after ourselves and keeping ourselves healthy, is there any link or rationale for just thinking about that, I guess, speaking as someone who lives in a city area and has got an open fire at home. I'm looking forward to lighting.
I don't want to get everyone to remortgage and move house now into the countryside, see a mass exodus. Probably not. I guess it goes back to the principle of talking to smokers who will come to clinic and say, well, shall I give up smoking now? And of course, you know, as a doctor, I say, well, of course you should try, and it's only going to help your general health. But that mutation, the pollutant or the carcinogen that does it, it happens over such a long period of time. So what's driving that initial, sadly, change that's converted it to a cancer takes a lot of chronic exposure. So once you've got that, I can't see why then ongoing exposure is not going to then drive any change or worsen your chance of responding to treatment or make things worse for you. Sadly, I guess it's one of those where now we know about it, are there ways where we can, I think this is going to be a case of trying to avoid patients from acquiring the cancers in the first place. But no, I don't see this as driving anything further.
This is just a really quick question. Obviously, with all the TKIs, when you've on sort of kind of the loratinib, you are a bit worried what the next step is. When you go into chemo, on any studies, what is the average that the chemo works for? I know everyone's different, but it's just, you know, like, as on an average, they normally say, oh, this one works for this time. Is it? So
it's always difficult to answer this question when you've got patients or people who may end up going on that treatment. The problem, in all honesty, so there are 2 chemo options that we broadly look at in terms of when patients progress. One is the IMpower 150 regime, where you get the 4 drugs, the immunotherapy, bevacizumab, and then 2 chemotherapy drugs. And then there's also what was used a long time ago, but something called carboplatin or chemotherapy with pemetrexed, which it's probably got a bit of a resurgence at the moment, because I think IMpower 150, there was a lot of excitement about that, looking at patients with driver mutations. But I think the longer term follow-up is showing that maybe we don't have to be as aggressive and carboplatin pemetrexed may be enough as it is. The problem is or if not all the trials with these drugs, so Empower had very few ALK patients in it. And our carboplatin pemetrexed is really based on old school. It's a very old school regime that predates even the identification of ALK. So yes, we treat ALK patients with it. The average, I guess the trouble with chemo is with your targeted therapies, we talk about a very high chance of response. So the majority of patients that you will go on a ALK targeted therapy, the treatment will work. Unfortunately, with chemotherapy, it is more of tossing a coin about how effective it is. It going to work or not? For those where it will work, look, the average may sit at around 6 months, but I've got plenty of patients who have done significantly better than that. And it's like with everything, there is always an average. And as I said, we don't have that ALK-specific data. There is a feeling that ALK tumors respond quite better to pemetrexed, which is why now with the slightly more subdued long-term follow-up for the Empower regime, there's a bit more of a trend going back to the pemetrexed chemotherapy. But both I wouldn't say that either regime is wrong. I think both are treatment options. It's what I say to my patients, and I'm always open about prognosis, always open about what's the chance. But look, the main thing is if you're fit enough, let's go for it, open-minded. Forget the figures. This is your journey. I know you want to plan, and you're doing the right thing, which is with Deborah's support, you're getting an insight to what's going on nationally, internationally, what's around the corner. If you reach another sticking point, just make sure that you're not missing out on a trial. Is this the right treatment for you? And if it is, you are going on a treatment, doesn't matter what the figures are. This is your journey. If I told you it's 6 months, it doesn't matter if you did 12 months, and that figure's irrelevant. If you're fit enough, go for it. And just as long as you know, with all the knowledge you're gaining from these sessions, that it's the right treatment for you, that's the best I think you can do.
Yeah, because I was on electinib for, it was nearly 4 years. Then, fortunately, I had progression in the brain. But then I was all set for cyberknife, but apparently it was too near the optic nerve, so I couldn't have it done. So then I then changed to loratinib, and I've done really well, and I'm on it for 1 year and 9 months now. So but you can't help but worry in the next step. And I'm actually thinking of chemo as being like, hopefully, just a stepping stone. So if I need to go on it, it'll be for a short time, and then hopefully the new Valiant trial will be available, or it'll be a bit further down on the phase trials.
Yeah.
So I'm just, that was my hope in the thinking of how long the chemo would work for, so I could use it as a stepping stone. And just something in between,
It's my take, but I always tell my patients, don't be scared of chemo. Don't look at it as a stepping stone. Look at it as another effective. If it's working well for you, it's working well for you. And I've had patients do exceptionally longer on chemotherapy and tolerate it very well. So don't think of it that way. And yes, the field may evolve so that if you do need to come off chemo, there is something else. But I always try and encourage my patients not to look at chemo as the enemy.
Dr. Baijal, can I interrupt you there? Sorry. Can I just interrupt and say, can I introduce you to Terry? So, this is Terry. And everybody in this room needs to see Terry, because Terry has been on chemotherapy for how long now?
3.5 years.
3.5 years. So again, maybe we shouldn't be thinking of chemo as the enemy when our turn comes. But I just wanted to reiterate your message.
Thank you.
So, sorry for interrupting.
Can I carry you around with me whenever I do a talk?
Yeah, exactly. Yeah. So, thank you, Terry.
No, that's brilliant. Thank you, Deborah, because that really does show what Terry's doing, and that happens, and that does happen. So don't think of it as another effective treatment option for you. Say that again, sorry. Potentially it will be the same as whether you've had TKI or not had TKI before. So we definitely know that going on TKI, that's a given now, that we knew that from the crizotinib days. That was the TKI at the beginning, 100% is better than. It definitely still should be left for after you've exhausted your TKIs, but it still is a very good option for you.
Thank you very much indeed. I'm looking to jump on stage now. Oops. Oh gosh. Thank you. I'm getting old. I think we've just had a fantastic session. Everyone would agree, and we should show our appreciation. Thank you. I am especially impressed that Dr. Baijal has been so brave to just rock up here and stand up in front of you lot. And I did warn him you were well educated, and you proved my point well. But thank you very much indeed.
Well,
thank you.
Giving
Giving up his Sunday. Thank you.